Somebody please answer. You can hear me? Hello. তোমরা কি শুনতে পাচ্ছ আমাকে?
জি স্যার।
আচ্ছা, থ্যাংক ইউ। তো সবাই ভালো আছো, তাই তো?
জি স্যার, আপনি ভালো আছেন?
আচ্ছা, মোটামুটি ভালো। তাহলে আমরা আজকের লেকচারটা শুরু করি। ম্যাচুরিটি দেখি, লাংস ম্যাচুরিটি অফ দ্য লাংস। আমরা এটাকে কয়েকটা স্টেজে ভাগ করতে পারি। First, the pseudo-glandular period during the 5 to 16 weeks of intrauterine life. This is known as pseudo-glandular period. Here, the branching has continued to form terminal bronchioles. No respiratory bronchioles or alveoli are present in this stage, the pseudo-glandular period during 5th to 16th weeks of intrauterine life. So then canalicular period, which persists from 16 to 26 weeks of embryonic life. Each terminal bronchiole divides into 2 or more respiratory bronchioles, which in turn divide into 3 to 6 alveolar ducts. Then terminal sac period, which persists up to 26 weeks, from 26 weeks up to birth. Here, the terminal sacs of primitive alveoli are formed and capillaries establish close contact. These capillaries are in close contact with each other during the terminal sac period. And next, alveolar period, which persists from 8 months to childhood. Mature alveoli have well-developed epithelial, endothelial, capillary contacts. So somebody claims that there is another stage named as secular stage, which persists from 24 weeks to 40 weeks. Here, alveolar ducts and hair sacs are developed. This secular stage. So we can divide the developmental stages of human lungs in 4 to 5 periodic periods, such as embryonic, pseudoglandular, someone claims embryonic period, pseudoglandular period, canalicular period, secular period, or terminal sac period, and alveolar period. So embryonic period, 4 to 5 weeks embryonic period. Here the lung buds originate as an outgrowth from the ventral wall of the foregut, where lobar division occurs. Embryonic period. Then pseudoglandular period from 5 to 17 weeks, conducting epithelial tubes surrounded by thick mesenchyme are formed. Extensive airway branching occurs in this period. And then canalicular period from week 16 to 25 or 26 weeks. Here the bronchioles are produced, increasing number of capillaries in close contact with cuboidal epithelium and the beginning of alveolar epithelium development during canalicular period. And then secular or terminal sac period, which 24 to 48 weeks or up to birth, or somebody says 26 weeks to birth. Here alveolar ducts and air sacs are developed. That is, the terminal sacs of primitive alveoli are developed and capillaries establish close contact with each other. And then alveolar stage, 8 months and late fetal to 8 years, 8 months to childhood, 8 months to 8 years, secondary separation occurs, that is, mature alveoli have well-developed epithelial endothelial contours. Here, secondary separation occurs, marked increase in the number and size of the capillaries and alveoli. This is the alveoli period. So these are the maturation periods of human lungs. So, if we consider again the embryonic stage, that is 4 weeks to 5 weeks, here lung buds originate as an outgrowth from the ventral wall of the foregut, while lower division occurs, which we saw in our earlier figures. During 4 to 5 weeks embryonic stage, lung buds originate as an outgrowth from the ventral wall of the foregut, while lower division occurs. And endoderm, tubular ventral growth from foregut pharynx. Mesoderm gives rise to mesenchyme of the lung buds, and intraembryonic coelom, pleural cavity elongated spaces connecting pericardial to peritoneal spaces, pericardio-peritoneal space. Then pseudoglandular stage, that persists from 5th week to 17 weeks. Here, tubular branching of the human lung continues. By the 2 months, all segmental bronchi are present. Segmental bronchi are present by 2 months, and lungs have appearance of a gland-like structure. So this is pseudoglandular stage, and stage is critical for the formation of all conducting airways. And in this stage, the lungs is lined with tall columnar epithelium. More distal structures are lined with pubertal epithelium. Here we can see that up to the 7th prenatal month, the bronchioles divide continuously into more and smaller canals, canalicular space. This is the bronchioles divide more and more rapidly. Large and smaller canals are formed in this period, with this canalicular phase, and the vascular supply increases. These are the blood capillaries. Vascular supply increases steadily. Respiration becomes possible when some of the cells of the pubertal respiratory bronchioles change into flat cells. Pubertal cells change into flat cells. These cells are intimately associated with numerous blood and lymph capillaries, and the surrounding spaces are now known as terminal sacs or primitive alveoli. These are the terminal sacs or primitive alveoli. During the 7th month, sufficient numbers of capillaries are present to guarantee adequate gas exchange. With the 7th month of intrauterine life, sufficient numbers of capillaries are formed to ensure adequate gas exchange of oxygen and carbon dioxide, and the premature infant is able to survive. So during 7th month of intrauterine life, if labor occurs or if the baby is delivered, he or she may be survived. So during the last 2 months of prenatal life and for several years thereafter, the number of terminal sacs increased steadily. Terminal sacs increase during the last 2 months of the prenatal life up to several years thereafter, usually up to 8 years. So in addition, cells lining the sacs known as type 1 alveolar epithelial cells become thinner, so that surrounding capillaries protrude into the alveolar sacs. Surrounding capillaries will be here, the capillaries protrude into the alveolar sac. And this intimate contact between epithelial and endothelial cells makes up the blood-air barrier. Here, the blood-air barrier is formed. Mature alveoli are not present before birth. These mature alveoli are not present during birth. So, in addition to endothelial cells and flat alveolar epithelial cells, another cell type develops at the end of the 6 months. These cells, known as type 2 alveolar epithelial cells, they produce surfactant. Previously, we saw type 1 alveolar cells, lining the sacs, and now type 2 alveolar cells which produce surfactant. Before birth, The lungs are full of fluid that contain a high chloride concentration, little protein, some mucus from the bronchial gland, and surfactant from the alveolar epithelial cells. So before birth, lungs, which components are present in the lungs? The lungs is full of fluid. The fluid contains high chloride ion concentration, little protein, some mucus, and bronchial glands. Some mucus from the bronchial glands and surfactant. Surfactant is secreted from the type 2 alveolar cells. This is alveolar type 1 cells. This is alveolar type 2 cell. So type 2 alveolar cells release surfactant. This is the surfactant layer. Surfactant layer in the So the amount of surfactant in the fluid increases, particularly during the last 2 weeks before birth. The surfactant is very much important for the functioning of lungs. So this is the alveolar type 2 cell which release surfactant. This is the surfactant layer. This is the air space, and this is the total alveolus. This is alveolar macrophage. Here lies the alveolar fluid, tubular myelin. This is the tubular myelin, and lamellar body in the alveolar type. This is lamellar body. So you should keep in mind that surfactant is released from the alveolar type 2 cell. So fetal breathing movements begin before birth and cause aspiration of amniotic fluid. So breathing movements begin just before birth and cause aspiration of the amniotic fluid. These movements are important for stimulating lung development and conditioning respiratory muscles. When respiration begins at birth, most of the lung fluid is rapidly resorbed by the blood and lymph capillaries, and a small amount is probably expelled via the trachea and bronchi during delivery. When the fluid is resorbed from alveolar sacs, surfactant remains deposited as a thin phospholipid coat on alveolar cell membrane. Here, alveolar cell membrane surfactant is distributed in the alveolar cell membrane. Without the fatty surfactant layer, the alveoli would collapse during expiration, which is known as atelectasis. If surfactant is not present, the lungs will collapse. These are the alveolus will collapse. So surfactant is very much necessary for normal functioning of alveolus and normal anatomical activities of the alveolus. Respiratory movements after birth bring air into the lungs, which expand and fill the pleural cavity. So the baby cries, and during the cry of baby, the respiratory movement occurs steadily after birth, and which brings air into the lungs, which expand, and the lungs expand and fill the pleural cavity. Although the alveoli increase somewhat in size, growth of the lungs after birth is due to primarily an increase in the number of respiratory bronchioles and alveoli. You should also keep in mind that the lungs increase after birth due to the increase in number of respiratory bronchioles and alveoli, not due to size. Lungs increase in size due to the increase in number of respiratory bronchioles and alveoli. It is estimated that only 1/6 of the adult number of alveoli are present during birth, and the remaining alveoli are formed during the first 10. Someone says first 8. So you keep in mind that the remaining alveoli are formed during the first 8 to 10 years of postnatal life, show the continuous formation of new primitive alveoli. So formation of alveoli is an ongoing process which persists up to the 10 years of postnatal life. So now growth of lungs into the body cavity. In the figure, this is the splenic mesoderm, this is intermediate mesoderm, this is the primitive gut, this is the aorta, this is the somatic mesoderm, this is intraembryotic cellum. So foregut endoderm surrounded by visceral or splanopludic mesoderm, and suspended in the body wall by dorsal mesentery. This is the dorsal mesentery. As lungs grow, they expand into the body cavity. During the growth of lungs, they expand in the body cavity. The lung buds punch into the visceral mesoderm. The lung bud punch into the visceral mesoderm. The mesoderm, which covers the outside of the lung, develops into a visceral pleura. This mesoderm then develops into a visceral pleura. This is visceral pleura. The red colored area is the visceral pleura. The somatic mesoderm covering the body wall. Here, the somatic mesoderm covers the body wall, which forms the parietal pleura. This is the parietal. So, this is the visceral pleura. This is the parietal. And the space between these pleura, known as pleural space. Pleural space. Here, the pleural fluid is present. Here, the pleural space of pleural cavity. Pleural cavity is the cavity that persists between the visceral pleura and. So, visceral pleura is formed from the visceral mesoderm, and the somatic mesoderm gives rise to parietal pleura. The space between the visceral pleura and parietal pleura is known as the pleural cavity, which is filled with pleural fluid. The space between this is the pleural cavity. So, in 7 ways, further maturation of the pericardium expands pleural cavity. Here, the pleural cavity, pericardial cavity, pleural cavity, this is the pleural cavity. And in 8 ways, lungs grow and expand into pleural cavity. The lungs grow and expand into pleural cavity. This is the pleural cavity. These are the lungs. This is the lung which expands into the pleural cavity. As the embryo folds, during the folding of embryo in this direction, a connective structure, the septum transversum, forms between the heart and the body stalk. This is septum transversum. Septum transversum is formed. This septum transversum is formed between the heart and the body stalk. Body stalk is between the heart. The septum transversum is formed here. This is the septum transversum. Those separation of abdominal and thoracic cavities lead to development of the septum transversum and diaphragm. So yes, septum transversum and diaphragm can separate the abdominal cavity from the thoracic cavity. These are the thoracic vertebral, lumbar vertebrae. This is septum transversum. Septum transversum, which creates the division between the thoracic and abdominal cavity. The extension of the septum transversum partially divides abdominal and thoracic cavity. The septum transversum goes in a roughly transverse plane from front to back. Is initially at the level of cervical 1. Initially at the level of the cervical 1 is here. The septum transversum at the level of the first cervical part is here. But is displaced totally by differential growth of the embryo. While the embryo grows, the septum transversum is then displaced totally. In the region of the thoracic. At 5th to 6th weeks, myoblasts migrate into the septum. Myoblasts migrate into the septum, carrying innervation with them. Ventral rami of cervical 3, 4, and 5. So, at the 5th to 6th weeks of development, myoblasts migrate to the septum transversum, producing innervation from the ventral rami of cervical 3, 4, and 5. Hence, the force of the phrenic nerve. See the force of the phrenic nerve. The phrenic nerve supplies the diaphragm. By week 8, is angled downwards such that front of the septum is at about 7 thoracic vertebra, back edge is at about 12 thoracic vertebra, similar to adult. This is 7 thoracic vertebra, then back edge at the 12 thoracic vertebra. 7 thoracic and back edge at the 12 thoracic, similar to adult. And almost similar to adult. In the heart, septum transversum. The septum transversum stops at the gut tube, leaving two open passageways on the left and right sides, the pericardio-peritoneal canals. Pericardio-peritoneal canals. Pericardio-peritoneal canals. This is septum transversum. Septum transversum stops at the gut tube, leaving two open passageways on the left and right sides, known as pericardio-peritoneal canals. The pleural canals shown on the pericardio-peritoneal canal. The closing of these canals require growth from the dorsolateral body wall, that is pleuroperitoneal membranes. These are the pleuroperitoneal membranes. Pleuroperitoneal membranes. So defects in this process cause congenital diaphragmatic hernia. Abdominal contents herniate into the pleural cavities and interfere with lung development. This congenital diaphragmatic hernia we already discussed during the study of head, and the GIT. So if this pleuroperitoneal membrane is not developed properly, this pleuroperitoneal membrane is not developed properly, then congenital diaphragmatic hernia in the fetus may develop. So congenital diaphragmatic hernia is relatively common, 1 per 2000 live births. Here is the congenital diaphragmatic hernia. The abdominal contents are pushed through this diaphragmatic hernia into the pleural cavities. These are the abdominal contents, which collapses the lungs, causing respiratory distress in the newborn. So this is congenital diaphragmatic hernia, which is relatively common in 1 per 2000 live births. Hiatal hernias are most frequent, but effects are rather minor due to small size. The hiatal hernia is the hernia in which the abdominal contents pass through a small opening or the small hole of the diaphragm. In the hiatal hernia. But in congenital diaphragmatic hernia, the respiratory membrane is not developed properly. That is, the septum transversum is not developed properly. A large portion of the abdominal contents pass into the thoracic cavity, which causes the collapse of the lungs, creating respiratory distress to the newborn. Hernias due to failure of one or both pleuroperitoneal membranes to close off pericardio-peritoneal canals have much more significant clinical impact because herniated abdominal contents interfere with lung development. 80 to 90% of hernias with clinical impact are on the left side. The left side. 80 to 90% lie in the left side. There is absence of pleuroperitoneal membrane, and through these absence, the abdominal contents are herniated into the thoracic cavity. Opening of the respirator. 80 to 90% of hernias with clinical impact are on the left side. Large defects have high mortality due to extent of lung hypoplasia and dysfunction. Here is the abdominal contents passed into the thoracic cavity, left thoracic cavity. Abdominal contents passed into the left thoracic cavity, the newborn baby. This is X-ray picture. So during patterning of the lung, how patterning of the lung occurs? First three branching events are stereotyped. Trachea into two primary bronchi, left and right. Left and right, principal bronchi or primary bronchi. In the lung bud, in 32 days divides into left and right primary bronchi. This is the right bronchi, the left bronchus. Left primary bronchi divides into two. The left primary bronchus divides into two secondary bronchi corresponding to the two lobes of the left. Three secondary buds form on the right corresponding to the three lobes on the right, upper, middle, and lower. And here upper and lower, superior and inferior. Superior, middle, and inferior lobes. 10 tertiary or segmental bronchi form in the right lung, In the right lung, the 10 tertiary bronchi. 10 tertiary or segmental bronchi are formed in the right lung, and 8 tertiary bronchi are formed in the left lung. So establishing the 18 bronchopulmonary segments, total 18 bronchopulmonary segments of the adult human lung. This is the patterning of the lung. This is the patterning. Total 18 bronchopulmonary segments. As a dissected embryonic mouse lung, right side cultured unperturbated after dissection, bronchitis covered with tracheal mechanism. No branching occurs at left bronchitis due to the tracheal mechanism inhibition. In the left, here no bronchial branching occurs due to tracheal mechanism inhibition. Here in the right, branching occurs. So these are the genetic signaling for the lung growth. The tuberous growth factor and BMPs play major roles in the signaling. Going in details. By the end of the 6 months, 17 generations of subdivisions are formed. 6 more divisions occur during postnatal life for a total of 23 branching events in the adult human lung. Branching continues to be regulated by epithelial mesenchymal interactions, deriving from the endodermal epithelial lung mass and the hemicapital. So branching morphogenesis in the lungs is mesoderm and retinoid dependent. You should keep in mind the retinoid. Retinoid plays a major role in the development of the mature lung. The late disruption may have minor effects, while the early disruption may result in hypoplasia or even agenesis. The stages of maturation of the lungs, which we already discussed earlier, in pseudo-glandular period 5 to 17 weeks, discussed. And these, by the 17th week, all major elements have been formed except those involved with gas exchange. So fetus is unable to survive being born at this stage. Within 17 weeks, if a fetus is born, he or she cannot survive due to failure of the development of gas exchange unit of the lungs. Canalicular period. In 16 to 26 weeks, terminal bronchioles become larger. When terminal bronchioles become larger, and lung tissues highly vascular. These are the vascular tissues. Surfactant production begins around 22 weeks, but not enough to prevent airways to collapse. Alveolar ducts with terminal sacs form by 24 weeks, so limited respiration is possible by 24 weeks. Terminal sac period. Secular period persists 26 weeks to birth. Many more terminal sacs develop. These are the terminal sacs. More terminal sacs are developed. More terminal sacs are developed with very thin epithelium and capillaries bulging into the developing alveoli. Capillaries are bulging to the developing alveoli. Blood-air barrier is formed. Surfactant production is sufficient to prevent atelectasis. Atelectasis means collapse of the lung. Collapse of the bronchioles. So in alveolar period, that is the late fetal period to age 8, alveoli-like structures are present by 32 weeks. Alveoli-like structures are present by 32 weeks. Epithelial lining of sacs attenuate to extremely thin squamous epithelia capable of gas exchange. 95% of the characteristic mature alveoli develop after birth. This is the canalicular period. After terminal bronchioles, pivotal epithelium in terminal sac period, that is alveolar stage. This is alveolar period. The vascular supply is more dominant in alveolar period. Late fetal through childhood, type 2 surfactant producing cells are present here. So at birth, alveoli continue to mature after birth and become more muscular Growth of lungs after birth due primarily to increase of respiratory bronchioles and alveoli. Only 1/6 of adult alveoli are present at birth. Lungs are fluid-filled, fluid squeezed out and into lymphatic and blood vessels expelled via trachea at delivery. Surfactant remains on surface towards air blood retention. The surfactant A. Surfactant A activates macrophages to elicit uterine contractions. Also important in post-defense. The surfactant A is released from the embryonic lung tissue, which is important for the contraction of the uterus and also post-defense. Surfactant B organizes into tubular structures that are much more efficient at reducing surface tension. Specific deficiency in surfactant B can lead to a respiratory distress. So it is the surfactant B, the deficiency of which is related to the respiratory distress syndrome of the baby. So surfactant B is much more important. Surfactant C enhances function of the surfactant phospholipids. And surfactant D is important in both. So there are 4 types of surfactant we have already seen. Surfactant A, B, C, and D. Surfactant B is more important for maintaining the lungs of the collapse. So now, what is respiratory distress syndrome or hyaline membrane disease? This disease affects 2% of live newborn infants, with prematurely born being most susceptible. 30% of all neonatal disease results from this hyaline membrane disease or its complications. So this is the disease which is established or which occurs in newborn babies due to the absence of surfactants in the lungs, which causes atelectasis of the lung, that is the collapse of the lungs, and respiratory distress of the baby. 30% of all neonatal disease results from this respiratory distress syndrome or hyaline membrane disease. The surfactant deficiency is the major cause of respiratory distress syndrome or hyaline membrane disease. The lungs are underinflated and the alveoli contain a fluid of high protein content, probably derived from the circulation substances and injured pulmonary epithelium. In addition to prematurity, prolonged intrauterine asphyxia may produce, it is usually called birth asphyxia, irreversible changes in type 2 alveolar cells, rendering them incapable of producing surfactant. So, in case of premature baby and in case of birth asphyxia or in case of prolonged labor, the baby may experience more asphyxia due to irreversible changes or irreversible damage in type 2 alveolar cells. These type 2 alveolar cells secrete surfactant. So due to the injury to these type 2 alveolar cells, surfactant cannot be produced, which will create respiratory distress in the newborn. Other factors may contribute to surfactant deficiency, but the genetics of surfactant production are not well defined. So prolonged labor, breathing damages, prolonged labor or prolonged breathing, prolonged labor breathing damages alveolar epithelium, leading to a protein deposition known as hyaline. Here, protein is deposited here, now known as hyaline in the membrane, respiratory membrane. So this is known as hyaline membrane disease. So what happens in respiratory distress syndrome? Here, surfactant is particularly important for survival of the premature baby. When surfactant is insufficient, the air, water, or air blood surface membrane tension becomes high, bringing great risk that alveoli will collapse during expiration. As a result, respiratory distress syndrome develops. This is the common cause of death in the premature infant, 30% neonatal death. In these cases, the partially collapsed alveoli, these are the partially collapsed alveoli, this is the normal alveoli, this is the normal alveoli in a normal child, this is partially collapsed alveoli. contain a fluid with a high protein content, many hyaline membranes, and lamellar bodies, probably derived from the surfactant layer. The recent development of artificial surfactant and treatment of premature babies with glucocorticoids, such as with treatment with vitamin injection, to stimulate surfactant production have reduced the mortality associated with respiratory distress syndrome. So now the modern treatment with artificial surfactant and with steroid injection, the steroid stimulates surfactant production, which reduce the mortality associated with respiratory distress syndrome. It also allowed survival of some babies as young as 5.5 months of gestation. Then agenesis of lungs. Agenesis of lungs can occur bilaterally or unilaterally due to early failure of the respiratory bud to develop an obligate branch. So due to insufficient megaderm, teratogens, alcohol, genetic mutation, etc. Unilateral lung agenesis is compatible with life. Remaining side usually hyperexpands and if a baby has unilateral lung, that is lung in one side, and there is no lung on the other side, is lung then compatible with life. Life with some limitations. Oligohydramnios. One oligohydramnios reduced immunity fluid that is less than 500 ml. Less than 500 ml. This is known as oligohydramnios. This is called severe lung development. Oligohydramnios create retardation in lung. And severe pulmonary hypertension may result due to oligohydramnios. There may be ectopic lung lobes, or accessory lobe. Ectopic lung lobe arising from the trachea or esophagus will show in early figure, that is lungs arising from the esophagus. It is believed that these lobes are formed from additional respiratory parts of the throat that develop independently of the main respiratory system. This is the accessory lobe. The congenital lung cyst, here in the congenital lung cyst, cysts that is filled with fluid or air are thought to be formed by the dilatation of the terminal bronchi, probably due to branching irregularities in later development of fetus. If severe, cysts are visible on radiographs. Highly variable outcomes result from different cystic conditions. These cysts may be small and multiple, giving the lung a honeycomb appearance. Here you can see the honeycomb appearance of the cystic lung. Or they may be restricted to one or more larger ones. Cystic structures of the lung usually drain poorly and frequently cause chronic infections. This is lung hypoplasia. In infants with congenital diaphragmatic hernia, the lung is unable to develop normally. This lung cannot develop normally due to congenital diaphragmatic hernia, and it is hypoplastic lung. Because it is compressed by the abnormally positioned abdominal cells, it is characterized by reduced lung volume. This lung volume is reduced. Most infants with congenital diaphragmatic hernia die of pulmonary insufficiency as their lungs are too hypoplastic to support life. So, how can you differentiate between a stillbirth baby and a dead baby after birth? This is the way. Fresh and healthy lungs contain some air, so pulmonary samples float inward. If a baby died after birth, his lung was able to inhale oxygen. So if the lungs is placed on a bucket of water, the lungs will float in the water. But in a stillborn baby, the lungs of the stillborn infants are firm and hard, and that will sink in the water because they contain fluids, not air. So this is the differentiating point. একটা বাচ্চাকে জন্মানোর পরে মারা হয়েছে নাকি সে মৃত অবস্থায় জন্মগ্রহণ করেছে, এটা ফরেনসিক মেডিসিনের একটা সেটা প্রমাণ করার উপায়টাই যে একটা মৃত বাচ্চার লাংসকে যদি পানিতে ডুবানো হয় এবং যদি সেটা পানিতে ডুবে যায় তাহলে বুঝতে হবে সে মৃত হিসেবে জন্মগ্রহণ করেছিল, মৃত বাচ্চা ছিল। আর যদি সে পানিতে ভাসে তাহলে বুঝতে হবে তার জন্মের পরে তাকে মারা হয়েছে। এভাবে আমরা ডিফারেন্সিয়েট করতে পারি মৃত বেবি জন্মের আগে বা জন্মের পরে। আমরা কিছু জিনিস জানলাম যে ফার্স্ট ব্রিথ, the fetal respiratory movements or fetal breathing movements are regular muscular contractions occurring in the third trimester of the life, intrauterine life. So preparing the respiratory muscular system for neonatal function may also have a role in the the fetal state. So the respiratory system does not carry out its physiological function of gas exchange prenatally and remain entirely fluid-filled until birth. At birth, fluid in the upper respiratory tract is expired and fluid in the lung alveoli is rapidly absorbed. This event also has been called dewatering of the lung. The lung epithelia has to now rapidly change from its prenatal secretory function to that of fluid absorption. আমরা একটু respiratory rate সম্পর্কে বলি। In neonates, the respiratory rate is higher, 30 to 60 breaths per minute than adult. In adult, respiratory rate is 12 to 20 breaths per minute. Infant that is birth up to 1 year, 30 to 60 breaths per minute in respiratory rate. In toddler, 1 to 3 years of life, 24 to 40 breaths per minute. And preschool children, that is 3 to 6 years of life, 22 to 34 breaths per minute. And school age, that is 6 to 12 years of life, 18 to 30 breaths per minute. And in adolescent, that is 12 to 18 years, the respiratory rate is 12 to 16. So there are some respiratory tract abnormalities, such as Meconium aspiration syndrome, MES. The Meconium aspiration syndrome, meconium is the GIT contents that accumulate in the intestine during the fetal period. Fetal stress in the third trimester prior to parturition can lead to premature meconium discharge into the amniotic fluid and subsequent injection by the fetus and damage to respiratory function. The damage to placental vessels, meconium myonecrosis may also occur. A newborn respiratory distress, which is Haaland-Mitten disease, we already discussed due to the absence of surfactant, it occurs. And tracheosphereal fistula, we already discussed. There may be lobar emphysema, that is overinflated lung. In the left upper lobe, due to collapse, lower lobe, the left lung is herniating across the mediastinum, may cause lobar emphysema. Congenital abdomen discussed. Azygous lobe, congenital laryngeal waves, and bronchopulmonary dysplasia. These are the congenital abnormalities that the newborn baby may face. A newborn may have asthma due to flow limitation during tidal expiration in early life, significantly associated with the development of asthma by the age of 2 years. Infants with abnormal lung function soon after birth may have a genetic predisposition to asthma or other abnormalities that predict the risk of subsequent lower respiratory tract illness. There may be cystic fibrosis in child, inherited disease. Cystic fibrosis is an inherited disease of the mucus and sweat glands, causing mucus to be thick and sticky, clogging the lungs, causing breathing problems and encouraging bacterial infection. So as we, during the start of our discussion, we said that there are some environmental factors which may influence development of the lungs in fetus. So these environmental factors, the lung is most sensitive to environmental effects given the long time course of development, including postnatal, multi-system origins, immune interactions, and our growing understanding of the effects of the prenatal environment on adults. So there are some environmental factors which may influence the development of the lungs, which include maternal alcohol ingestion, maternal obesity, maternal diabetes, maternal smoking, maternal chronic hypoxemia, and if there is any chemical exposure of the environment. So these are the environmental factors which may influence growth of the respiratory systems of the baby. So I want to conclude my discussion on development of lungs here. If you have any questions, please contact me through the email. And I want to conclude my discussion today. Be safe and be healthy. Thank you.
Thank you, sir. Assalamualaikum.